Lens replacement surgery can be life-changing for the right patient, but it is still eye surgery. One of the biggest mistakes someone can make is only focus on the benefits. They hear words like premium lenses or permanent vision correction, but they don't really understand the trade-offs well. I was going to talk about multifocal lenses, but I thought I'll first go through the risks, recovery, and realistic expectations after lens replacement surgery. It's not to put you off, but it's just to help you make a more informed decision. Again, the information in this video is for general information purposes only, and it's not specific to anyone in particular. Refractive lens exchange is very similar to cataract surgery. We go into the eye and we remove the natural lens and we replace it with an artificial lens. The main difference is that in cataract surgery, there's usually already a visually significant cataract which causes worsening of the vision. Now, in refractive lens exchange, the natural lens that we replace is usually clear or very minimally cloudy. That means that they already have very good vision with the aid of glasses or contact lenses. But if they are looking to reduce dependence on glasses or contact lenses, then we consider refractive lens exchange. And that distinction is quite important because in cataract surgery, as I said, the vision may already be poor, whereas in refractive lens exchange, it's not yet affected. Now, that doesn't necessarily make the procedure wrong, because it's important to understand that the natural lens is being replaced with an artificial lens. It can be a very good procedure for the right and carefully selected patient, but it does mean that the decision has to be made very carefully. ROLE is usually considered in individuals who are developing age-related loss of near focus, which typically starts in the mid-40s. It may be particularly useful for people who have very long-sighted prescription or who are not suitable for corneal laser or are developing early cataract changes. It may be considered if someone just wants to reduce dependence on glasses and they understand the trade-offs involved. But it is not simply laser eye surgery for older people. It is intraocular surgery. So laser eye surgery works on the front of the eye, whereas for intraocular surgery we have to go into the eye to replace the natural lens. Now, that doesn't necessarily mean it's wrong. It just means this is important to understand that the risk profile is slightly different. So the question is not simply can we do it? It's that is the risk worth the benefit in this particular individual? And that's typically what should guide the consultation. Most patients want to know one thing: will I be free from glasses? And the answer is that ROLE can reduce dependence on glasses, sometimes quite significantly, but no responsible surgeon should promise complete independence from glasses. The result depends on several things. It depends on the health of the eye, the accuracy of the measurement, which lens implant has been chosen, is there any astigmatism, how the biological healing is in that particular individual, and it depends on which tasks are most important to the patient. A patient with monofocal lens, for example, for distance, should generally get very good vision for driving and watching TV, but they'll need to wear glasses for reading. If someone has monovision, for instance, they'll get distance as well as some intermediate vision, but the eye that gives them more intermediate vision may not be as good when tested individually for distance. If a patient has had a multifocal lens or an EDOF lens, then they may get more range of vision, but they notice more glare and halos, especially when driving in the dark, and they may also notice reduced contrast or dimming of vision. So the goal is not perfection, it's to find the best overall balance for that particular patient. Sometimes patients think that if they can read the bottom of the chart, then that means they have perfect vision. It's important to understand that vision is more than just letters on the chart. There are many other aspects, including glare, halos, contrast, how the vision is at night, how the vision is when driving, how well the two eyes work together comfortably, depth perception, reading comfort, and things like that. That's why two patients can have same measured vision but feel very differently about their outcome. One patient may be very happy with the outcome, but another may be very bothered by the amount of glare or halos or the small residual prescription that they may be left with. So when we talk about ROLE, we're not just talking about sharpness, we also talk about other aspects of the quality of the vision. And that's particularly important when considering premium lens implants, because the widest range of lens may not necessarily give the highest quality vision. In the first few days after surgery, it is common for the vision to fluctuate. There can be some grittiness, feeling like there's something in the eye, and a bit of discomfort. But most of the time it settles, although it can take a few weeks for that to happen. People may notice a bit of glare earlier on, a bit of misting. The pupil can be slightly larger, and that can contribute to some of these symptoms. Lights may seem brighter than normal. Many patients notice improvement quickly, but it can take a few days for the vision to improve. And the final quality of vision continues to settle over several weeks. If the two eyes are treated separately, there may be a period in between the operation where things can feel quite imbalanced. Now, the degree of imbalance can be affected by how strong someone's prescription is, so it's important to discuss that with your surgeon. Some patients can cope very well with it, but others may struggle more until the second eye has been treated. After the surgery, patients usually need drops to reduce inflammation and the risk of infection. The exact drops regime can vary between surgeons and clinics. It's important to follow the instructions that have been given and attend follow-up appointments. The operation does not end when the patient leaves theatre. Good aftercare is very important. Usually follow-ups exist so we can make sure that everything is settling as expected. We need to check the pressure, the cornea, the wound, lens position to make sure that things are settling down. If the vision isn't settling down as we expect, usually we need to look for reasons for that. Most recovery is straightforward, but follow-up exists because early detection of problems is quite important. One of the most serious risks after surgery is infection inside the eye. This is called endophthalmitis. It is quite rare, with the Royal College reporting incidence around about 1 in 1,000, but it can have a significant impact on the person's vision and can seriously threaten their sight. This is why surgery is performed under sterile conditions, and we take various infection prevention measures depending on the surgeon's protocol. The individual should know the warning signs, so if someone develops sudden increasing pain, worsening light sensitivity, a drop in vision, then they should consider these symptoms quite seriously and contact their surgical team or the local eye casualty as a matter of urgency. This is not to frighten the patient, it's just so that they know what to look out for and help protect the vision. Some inflammation is expected after the surgery, and that is why we use anti-inflammatory drops. Sometimes, though, the inflammatory response can be more significant than we expect and require additional treatment. The pressure inside the eye can also sometimes go up after surgery. This can be from a viscoelastic material that we use during the surgery. It can be from pre-existing glaucoma or ocular hypertension, which is a condition which causes an increase in pressure, or it can be related to steroid use. That's why it's important to measure the pressure after surgery and make sure that it is within the expected limits. Most pressure rise can be managed, but it just needs to be identified in a timely manner. Patients with glaucoma or ocular hypertension require particular care and counseling around the surgery. It doesn't mean they can't have surgery. It's just that we need to make sure we take appropriate measures around the surgery for them. Another possible complication is swelling at the back of the eye called cystoid macular edema. So using the eye model, if you look at the front, that's the lens that we've replaced. Now the back of the eye, that's called the macula. That's the part of the eye that's responsible for fine central vision. So if there is swelling or inflammation in that part, it can cause distorted vision. Most of the time it is treatable with drops, although rarely it can require additional treatments. The risk can be higher in certain individuals. So if someone, for instance, with diabetes or other retinal problems, or if they are more prone to inflammation, that's why it's important to have a retinal scan before the surgery. The lens implant sits in the front of the eye, but the final vision depends on the lens as well as the macula at the back. A premium lens cannot overcome a macula, and that's not healthy. Retinal detachment is another important risk to understand, especially in someone who is short-sighted. The risk of retinal detachment goes up in someone who's had lens replacement surgery compared to someone who's not had this. There are various factors which increase the risk of retinal detachment. These depend on age, the degree of short-sightedness, the length of the eye, the health of the retina, and various individual factors. People who are high myopes or are very short-sighted need to be counselled very cautiously. It can sometimes be considered in these individuals, but it's not a straightforward, simple cosmetic procedure. It's important to understand that if someone develops symptoms like flashes or new floaters or a shadow or a curtain appears in the vision, then they should contact their surgical team or local eye casualty urgently, because something like that does generally require prompt assessment. Retinal detachment is uncommon, but it is a serious complication if it occurs. So patients should understand that before choosing surgery. Now, before the surgery, detailed measurements are taken to help determine the power of the lens. Now, these measurements are very good, and the formula we use are usually quite accurate as well, but they are not perfect. The eyes are not factory-made optical instruments, they are biological tissues. So that means even with the best of planning, a small amount of prescription can remain even after technically successful surgery. Now, this could mean that the person requires glasses for certain tasks. Now, in some cases, we can consider additional procedures like laser or lens-based procedures to try and reduce that dependence on glasses. But in others, it may just be simplest and safest just to wear glasses. There are certain patients in whom the risk of needing glasses afterwards is slightly higher. So someone who's had laser eye surgery in the past, or if they have an irregular cornea, or if they have a very long or a very short eye, or they have less stable measurements. No one should tell the patient that the calculations are guaranteed. We, of course, always try to optimize the measurements, but biological variation can remain. So if, for instance, someone has 2 cuts on their skin, they will both heal slightly differently. So we always say that there is a small possibility of biological variation in recovery. Now, glare and halos are quite important when discussing EDOF, multifocal or trifocal lenses. These lenses aim to provide a wide range of vision, but the wider range can come with optical side effects. So patients may notice rings around lights, glare from headlights, starburst or reduced contrast, especially in dim light conditions. Now, many patients adapt to these over time. Some barely notice them at all. Others may notice them, but they find that the increased range is worth it. A smaller number can find them quite troublesome. The key point is that these symptoms shouldn't be discovered as a surprise after surgery, but these should be discussed before the surgery, especially if someone is particularly sensitive to phenomena like glare and halos, and they do drive at night quite a bit. Then it's important to spend some time around this part of the discussion with them. So the correct question is not which lens gives the most range, it's that which compromise is right for this patient. Dry eye is common in the patient group considering cataract and refractive lens exchange surgery. It can affect both vision and comfort. Some people can notice dryness, grittiness, or fluctuating vision after surgery. Now, if dryness is present before the surgery, it needs to be treated first. It's not just about the comfort of the patient. The quality of the tear film can actually affect the quality of the measurements used to calculate the lens in the eye, and that can therefore affect the result of the surgery. Sometimes patients think that it's just the choice of the lens which determines the result. The ocular surface is quite important as well, because if the front surface of the eye is unstable, then the visual outcome after the surgery may not feel stable either. After lens surgery, the artificial lens sits inside a structure in the eye called the natural lens capsule. Now, over time after surgery, this capsule can become hazy. This is called posterior capsular opacification. Some describe it as the cataract coming back. It's not the cataract coming back, it's just the capsule becoming more cloudy over time. This can affect the vision though, but it can be treated with a simple procedure called YAG laser. Now, YAG laser is a common procedure and is usually straightforward, although it is still an eye procedure and it does have some small associated risks to be aware of. Now, sometimes people worry, they feel that vision's going misty, sometimes months or years after the surgery, and they feel that something's gone wrong with the lens. It's usually just the case of the capsule becoming cloudy over time, and that can generally be treated. Most patients don't need further surgery after refractive lens exchange. However, sometimes additional procedures can be required. This can include YAG laser for capsular opacification. It can be for additional inflammation or macular swelling at the back of the eye. Some people may require laser enhancement if they have a residual prescription or a lens procedure. If someone's had a toric lens, sometimes it can require repositioning. Very rarely, if someone's really unhappy with their choice of lens, we can consider exchange of that lens as well. I will say though that lens exchange is not to be taken very lightly. It does carry additional risks and is usually more complex than the original operation. That's why choosing the right lens before the surgery is important, and the best way to deal with an unsuitable lens is to avoid choosing it in the first place. A good outcome does not mean that the patient never notices their eyes again. A good outcome means that the patient's vision has improved in a way that was realistically intended. The eyes are healthy, the lens is stable, the patient understands any remaining need for glasses, and the result matches the priorities which were discussed before the surgery. For one patient, success may mean good distance vision with the help of reading glasses. For someone else, it may mean good distance and intermediate vision with occasional reading glasses. For someone else, it could mean a wide range of vision with some halos that they find acceptable. So success is not the same for everyone, and that's why planning is quite important. Patients sometimes feel that surgery is something that's done to them, but it's important to understand that the patient also has an important role. They need to explain their priorities quite clearly. They need to mention important aspects like nighttime driving, any previous eye problems, their reading habits, and any concerns that they have. They need to understand that every lens choice involves a compromise, use their aftercare drops as advised, and also to seek eye help if any of the warning signs or symptoms develop. The best outcomes are usually from good communication, good planning, good surgery, and good aftercare. So it's not just the operation, it's the whole pathway. RLE may not be suitable for everyone. Patients should think particularly carefully if they are a young high myope, if they have significant retinal disease, or if they have significant eye disease, unrealistic expectations, or are seeking a guarantee of perfect glasses-free vision at all distances. Patients who may be very distressed by glare, halos, a small residual prescription, or requiring glasses for certain tasks afterwards may need to be counseled very carefully before choosing premium lenses. Sometimes the most ethical recommendation is not to operate. Sometimes it's to choose a simpler lens. Sometimes it's to treat the ocular surface first. Sometimes it's to wait. So good care isn't just about saying yes to everyone. It's about helping the patient make a decision that's most likely to serve them well. So to summarize, RLE can be an excellent procedure for the right patient. It can reduce dependence on glasses and provide stable vision after the natural lens has been replaced by an artificial lens. But it is still intraocular surgery, and risks include infection, very rarely loss of vision, inflammation, retinal detachment, dry eyes, glare and halos, pressure problems, macular swelling, and possible need for further treatment. Most patients, however, recover well. I just say that the decision should be made with careful consideration rather than hype. The most important question is this the right operation with the right lens in this particular patient with their expectations? That is the conversation that the patient should have before having lens replacement surgery. In the next video, I'll discuss multifocal and trifocal lenses in a bit more detail, how they work, how they can reduce dependence on glasses, and how they are not suitable for everyone. If you found this video helpful, please consider subscribing for clear and balanced information about cataract surgery, vision correction, and eye health. Thank you.